Good evening, everybody, and welcome to this monthly MedEClasses postgraduate lecture series in which we are going to talk about a very important topic of hypokalemia. This lecture series, as we've discussed earlier, is an event which we organize monthly, and we propose to have 36 such sessions covering the entirety of postgraduate relevant pediatric endocrinology. So we have been running on electrolytes for these last few sessions. We're on hyponatremia, hypernatremia, and today we talk about hypokalemia. Now, hypokalemia is very common in terms of pediatric practice, but Dr. Manoj, what do you think are the major causes? So today I'm joined by Dr. Manoj Agarwal and Dr. Vibha Yadav, who are fellows in pediatric endocrinology, who will be part of this program. So Dr. Manoj, what do you think in terms of from a pediatrician's perspective, how common are endocrine causes of hypokalemia?
So if we talk about the pediatric perspective, then the diarrhea and vomiting is major cause of the hypokalemia. So it is a normal in the for the pediatric, but we have to keep our eye and ear open to not miss the sinister pathology like RAS excess or tubulopathy or the Bartter or Jitterman syndrome, because this can cause the persistent and the chronic hypokalemia. So identifying etiology is a very major cause in this particular concern.
So, Dr. Vibha, what do you think are the pointers when somebody should start thinking that, okay, this is not a simple cause of hypokalemia, we are thinking of some form of a endocrine cause of hypokalemia?
Like when any patient comes with like a failure to thrive, not gaining weight and having like malnutrition and having multiple fractures, like in the case of RTA, it could be the cause of one of the hypokalemia. And we should not miss it because it would lead to very life-threatening complications of metabolic acidosis. And another another symptoms could be like paralytic ileus or having this could be many problems.
What would you look at in terms of hemodynamic status, which will tell you the likelihood of an endocrine cause? Which parameter you will look at?
So for the hypokalemia, there will be for the ECG you are talking about?
No. So I'm talking about what will be the pointer that this is an endocrine cause. So if this thing is high, you start thinking this is an endocrine.
Sir. Basically, BP. We will look for the BP. If it is high, then definitely there is the RAS axis. It is involved here. And
yes. So as Dr. Manoj and Dr. Vibha have said that the hypokalemia is very common in pediatric practice. We talked about hyponatremia. It is also common, but there are much more endocrine contribution, particularly of SIADH. Hypernatremia, which we discussed in the last session, is usually because of dehydration, or a chronic hypernatremia would basically is equivalent to diabetes insipidus. This is what we discussed. But when we talk about hypokalemia, there are many more acute causes. You may have a gastrointestinal loss, you may have diuretic cues, you may have urinary loss, which will be more common. But if you have chronic hypokalemia with hypertension, along with that severe failure to thrive in polyuria, you start thinking of tubulopathies and endocrine causes which may become relevant from that perspective. So we'll be starting the session. We'll talk initially about pathophysiology. Then Dr. Manoj will talk about etiology, followed by assessment and management by me. And Dr. Vibha has collated a number of interesting questions which are relevant from postgraduate perspective, which can come from that perspective. So as we have discussed, hypokalemia is a common finding, but often it becomes like a diagnostic challenge, which is there in that perspective. So one needs to be aware and open to the various possibilities which are there. So we had this 2-year-old boy who presented with failure to thrive and had a significant failure to thrive in the form of weight of only 8 kilograms and compromised height with hypokalemia. Now, based upon the workup, and we'll discuss subsequently as to how blood gas becomes very important in here in terms of evaluation, the patient had alkalosis, which was quite significant, and further workup showed a normal blood pressure. Along with that, a hypocalciuric situation and a low magnesium. So we had a child who has hypomagnesemia with failure to thrive with hypocalciuria. The most common diagnosis people make is that of Jitterman syndrome. But the challenge in the evaluation of hypokalemia is not to rush towards unusual causes, because common causes are more important. So what we should consider here was to look at malnutrition. So when we looked at the fractional excretion of magnesium, which was low, it suggested that this was primarily a cause of malnutrition causing hypokalemia rather than a tubulopathy. So we need to have a comprehensive assessment with regards to the evaluation before we reach to a particular cause, because that cause deserves a specific treatment in that perspective. So as discussed, we'll touch base about pathophysiology, followed by criteria and etiology, management, and then we'll go forward from that perspective. All of you can go and have a look at our website, learning.growthsociety.in, which has got validated modules with regards to different aspects of pediatric endocrinology. We have got our e-learning portal on YouTube, where now there are a large number of videos, and you can also access our courses, which provide validated tools for assessment and evaluation. We have specific courses in the form of fellowship in pediatric endocrinology and pediatric endocrinology for postgraduates, cater to specific needs of people at different levels of careers. We do conduct 3 programs on a regular basis in the form of a pediatric endocrine grand round, a pediatric endocrine focus discussion, and this PG lecture series, which cover entirety, and these are available routinely on Zoom and YouTube. All the recordings are there. There are 2 publications which are available through our website, as well as the Kindle book reader and a mobile application, which helps in terms of assessment and diagnosis. And Dr. Vibha will now start talking about the questions which can come and how we can go in that regard. So you also feel free to write on the chat box also in that regard. So Dr. Vibha, please go ahead.
Okay, thank you, sir. After having a wonderful discussion by Dr. Anurag and my colleague Dr. Manoj, and sir has covered a lot of questions, so it will be a quick revision. So the first question is, a 5-year-old child was brought to emergency room after experiencing multiple bouts of vomiting and abdominal pain over the previous 2 to 3 days. So the first question is, what would you get in electrolyte parameters? So kindly write your answer in the chat box. And
yeah, so kindly put on the chat box so that we know it's been interactive. So what are the electrolyte parameters you will expect? Vibha, what will you expect?
Sir, there will be metabolic alkalosis with hypokalemia, as there will be as there is a loss of gastric acid in the form of vomiting, and there is a loss of volume also. It will activate. And sorry, and the next question is explanation of this electrolyte disturbance. So kindly write the answer, please.
So I think people are writing in the Q&A. Hypokalemia, metabolic
Yes,
alkalosis. Dr. Dhwani is writing. Dr. Rajiv is asking in hypokalemia. This is question which we'll discuss later on. So hypokalemia. So what is the cause of hypokalemia here? Is it just the loss of potassium, Dr. Manoj, or is it something else?
So the cause of the hypokalemia is not directly, it is by the alkalosis, and due to the volume loss, it caused the RAS excess, and by that there will be the hypokalemia.
So very good. So carry on, Dr. Vibha.
Now the second question, a 10-year-old boy was admitted to PICU with the chief complaints of polyuria for 15 days and fever, vomiting and abdominal pain for 3 days. On examination, we found he had a mild dehydration and respiratory distress. His RBS was 450 and his blood ketones were 5.5. And his ECG showed the prominent U waves. So I think the diagnosis is quite clear, but the question is not the diagnosis. The question is, what is the most likely electrolyte abnormality present in this case?
So I think we can ask the audience to ask about this answer.
So kindly write the answer.
So you can use the chat box or the Q&A. So this child clearly is DKA. And you are saying that there is a specific finding on ECG, which is there, which is a direct clue for diagnosis. So this seems to have hypokalemia in that setting. So what is the significance of hypokalemia, Dr. Vibha, at diagnosis of DKA? Will you be worried about this child?
Definitely, sir, because if there is a hypokalemia at the time of the admission, so we have to be very cautious about the starting dose of the insulin, and we should delay the insulin for like 1 to 2. Definitely, we don't start the insulin at the treatment, and we also start the potassium in the hydration fluid.
This is very important. As Dr. Vidhu has already mentioned, this is DKA and hypokalemia. So we have to be very cautious in this scenario. We have to give potassium 20 millimoles per liter right in the first hydration fluid that you're giving. And then you also need to be very, very cautious in terms of deferring insulin. So carry on, Dr. Vibha.
Second question, at what level of electrolytes does the U wave appear on the ECG?
So I think that's an interesting question. Let's see if the audience was listening to the discussion or not. So maybe you people can just put it on the chat box or Q&A.
Okay.
So just
sir,
hold on. Let them answer, I think. So less than 2.5, Dr. Dhwani, less than 2, Dr. Vidhu. Which one is correct according to you?
So less than 2.5 it is.
So at less than 3, generally nothing much happens, but 2.5, you start having these problems. Of course, as the severity progresses, you will have the other variations will become more prominent. So this means that there is severe hypokalemia. Yeah.
And the next question is, how will you do the correction in the hypokalemia with the potassium of 2.5?
So this we have discussed. You will probably have to not give insulin. You have to give in the hydration phase. And this is unusual, but then you have to treat it accordingly.
Yes, definitely. Now moving to the next question. A 2-month-old boy with a failure to thrive, weighing 3 kg, and was admitted to PICU with the complaints of loose motion for 5 to 6 days. And he has hypotonia on examination. And his sodium was 139 and potassium was 2.8. And chloride was 112, pH 7.16, and bicarbonate was 14. So the question is, what should be the next step in this case?
So if I just summarize, you have a child who has diarrhea and who has presented with hypokalemia with acidosis. What's the anion gap?
So we have to calculate. This is the question. What is the what should be the next step?
So people can come up with an anion gap.
Yeah.
So anybody can write the anion gap here. So it's sodium minus potassium minus sodium minus chloride minus bicarbonate. So that will be 139 minus 126.
Around
that
12.
will be 13.
13.
So 13 will be, Dr. Manoj, normal or low or high?
Sir, 13 will be the normal for this patient.
So we have a child who has hypokalemia with acidosis. So what are the 4 differentials, Dr. Manoj, you will think of here?
So a hypokalemia with the metabolic acidosis, first DD would be come in the mind is the diarrhea. Second would be the RTA. Third is the treated with the ureterostigmodoscopy. And fourth will be the decay.
So pretty much diarrhea was the RTA, and often RTA can also have these loose motions which may persist. So that's a confusion between these two. So what will be the next step? I think the audience can just answer this question.
And the diagnosis already you have discussed it. So that was the next question.
So I think this is
now this is the last question. How would you distinguish the causes? Like after calculating the NIN, what will you do next to distinguish the causes?
So basically what Dr. Vibha is asking is, how do you differentiate diarrhea versus RTA?
Definitely.
And that we discussed very, very carefully and discussed. So hopefully, so we'll talk about normal anion gap, GI cause. Okay, would you look at anion gap in some other fluid as well? So we are talking about blood anion gap, which is normal. What about the urinary anion gap? So Dr. Manoj, what do you expect the urinary anion gap if it's diarrhea in this case?
So now, after this blood anion gap, we have to move towards the urinary anion gap. In the diarrhea, it should be the less, or in that RTA, there will be the high urinary anion gap because there will be the defective production of the ammonia. So in the diarrhea, there will be the production of the ammonia is normal. So urinary anion gap will be the normal. In the RTA, it will be the high.
So normal response, Dr. Vibha, in acidosis is what in terms of the anion gap, urinary anion gap?
So normal response, basically in the acidosis, the body has to excrete the acid.
Yes.
And the potassium
ammonium production will
be more in the form of ammonia. Exactly.
Yeah, and urinary anion gap will become
positive. Sorry, negative. It is negative.
So negative anion gap will really give you the right diagnosis in this scenario. Yeah, carry forward. Next.
The next question, a 4-month-old boy with a failure to thrive and hypokalemia of 2.6. On examination, he had normal blood pressure. And the VBG showed metabolic alkalosis 7.54 and bicarbonate of 33. So the question is, what should be the next step? If we go according to this algorithm, so what should be the next step after getting the normal blood pressure?
So this is a important scenario of chronic hypokalemia with a normal blood pressure, and there is a alkalosis which is there. So Dr. Vibha, what do you think is the most likely diagnosis at a 4 month of age?
So in the 4 month of age, the most likely diagnosis of the normal blood pressure, that it would be this. If we don't do the next steps, it would be Bartter syndrome.
So Bartter will be the most likely because the onset is very early. Gentlemen is too early to present like this. So Dr. Vidhu has already said urinary calcium. So this is an important investigation. So urinary calcium would be done, which will tell you. So carry forward from there.
And so how would you interpret the result of urinary calcium?
So urinary calcium was high. So this was suggestive of a Bartter syndrome, hypercalciuria.
What is gentlemen? And what is the preferred treatment for the disorder with nephrocalcinosis?
Okay. So anybody would like to volunteer? Indomethacin. Indomethacin is an important treatment with regards to hypokalemia. Dr. Manoj, anything specific for nephrocalcinosis?
Yeah, we have to start the amylorides in this particular case. And for the preventing, we can start the thiazides also.
Yeah, so thiazide will be a preferable drug in this scenario. So indomethacin with thiazide will be there. So very interesting case there, Dr. Vibha. Carry forward.
It will be going to be very quick.
So this is to be, so we will see who is answering first. So this is like more like a fastest finger first. So those who put the numbers first, we'll stop there. So first question, you can start asking one by one.
Every 0.1 increase in pH, potassium falls by?
Yes, Rajita Das has answered.
How much?
Okay, next.
Who has
Condition
answered?
Rajiv Das has answered.
0.4.
Condition with hypokalemia and metabolic acidosis.
Hold on. 0.4 or 0.6? What is the right answer?
That is 0.6.
0.6. So for every 0.1 change in the pH, potassium usually changes by 0.6. But we will give 0.4 also. 0.6 is the more appropriate answer. So go slowly. Yeah.
Okay.
Second.
Condition with hypokalemia and metabolic acidosis. Two conditions.
So, Dr. Dhwani has already said diarrhea and RTA. So perfect. Yeah.
Perfect. Sodium potassium ATPase pump is activated by?
By mean what? By mean some biological agent?
By any pharmacological agent or by?
Okay. So anybody? It is inhibited by digoxin. We know. So it is activated by? Anybody has the correct answer? Insulin?
Definitely, sir.
Yeah. Carry forward. Dr. Rajiv gave the right answer.
In GRA, that is
GRA is glucocorticoid remediable aldosteronism. Yeah.
Dash gene is switched by dash G.
Yeah. So Dr. Manoj talked a lot about this condition. Very interesting condition. Glucocorticoid remediable aldosteronism. You have hypertension, which is autosomal dominant. And there is a regulation of the production of aldosterone by ACTH and not by the renin. So this is a switch of CYP11B1 with CYP11B2, which is basically there. So this is an important condition to look at. Next.
Diagnosis of AME.
So what is the AME?
That is apparent mineralocorticoid excess is established by?
So you want, of course, genetic will be the answer, which is obvious. What else do you want? Any clinical response to a drug? So Dr. Dhani said response to aldactone. Absolutely correct. So if you respond to aldactone, you will get the diagnosis. Yeah.
This enzyme 11 beta HSD2, sorry, it converts dash to dash.
So what is the initial product and what is the final product? So Dr. Manoj talked about 11 beta HSD2 as a shield which is there for the mineralocorticoid tissues. So mineralocorticoid tissues, basically, they prevent them from hyperactivity of an agent which is 100 times or 1000 times more in concentration in the blood, which is, so anybody can write the answer quickly, cortisol to cortisone.
Yeah.
True? Correct? So this basically inactivates the cortisol to cortisone. Dr. Rajiv Das has given the right answer. So Dr. Rajiv and Dr. Dhani are the most highest in terms of the scores. Next time we'll do a quiz also probably in this format. It will be easier.
The cause of Liddle syndrome is?
So I think this is a very simple question. The cause of Liddle syndrome is inactive effect. Dr. Dhani has mentioned again. So correct.
Okay, the sodium chloride symporter defect causes. This is
Which
very simple.
syndrome? So sodium chloride symporter defect. Now, if I ask about activating or inactivating?
Sir, it is definitely inactivating.
So if you have activating mutation, what will you have?
Sir, this is
Gordon.
So
Gordon.
this is gentleman syndrome here. Otherwise, it will be the Gordon syndrome.
Gordon.
So again, Dr. Dhani has got it right. So I think any further questions, or we have finished?
There is one.
Yeah,
A condition with high renin and high aldosterone.
So high renin, high aldosterone.
Generally, we get low renin and high aldosterone. So there is a condition that causes high renin and high aldosterone.
So Dr. Rajiv has mentioned RAS, so renal artery stenosis.
Yeah,
Correct?
definitely. Sir.
So
the last question: condition with hyponatremia and hypokalemia.
yes.
Any
so
condition? Yeah.
hyponatremia, hypokalemia, both are losing from
Yes, both are losing.
furosemide. True. Diuretic use, tubulopathies,
Yes, sir.
gastrointestinal loss. Dr. Dhani again right.